Well, one thing that's important from Petra's work shows that you get radial cracking within the zirconia. Radial cracking within the zirconia. And if that's true, one has to put this at a high risk. One has to put this as a black box. Now, that does not say that you can, well, it does say to be careful. Here's a patient who presents from London, and she's a patient of yours, and she presented with these broken down veneers and a crown, and Odette Bahat did the implant surgery and grafting procedures. After he was done, I developed this. Look at the papilla that he was able to do, in my mind, absolutely brilliant, with a Nobel implant. And in this case, I used a titanium abutment that has micro grooves so that I have to put a thin resin material over it so that I can wax to it and create the lithium disilicate, press the lithium disilicate, and then cement that to place. Once that was done, this is a material, and the concept of doing these crowns was really rather easy. Anteriorly, this would be my choice. And most of the companies have these, although they're not clear where they're going with it. This is another patient that presents with a problem. We develop. We test the lithium disilicate model within the same time as our treatment wax. We make the lithium disilicate core, press that and cement. This is cemented to that titanium abutment, and then these are the final restorations. It takes me less than a day to make one of these. I'm not CAD-camming it. I'm not spending a lot of time doing it. From the point of view of financial incentive, this is a much better way to go than anything I'm going to do in the CAD-CAM world. Now, all of you know that I've done a lot of research in the statistical models of the all-ceramic world with Sokransky, and we've done this for 30 years. And you know as well that I've looked at these numbers with a very careful discussion with confounding variables, because that's where the magic is. And I've studied the concept of the survival from Kaplan-Meier and log rank test to understand what are the variables in this story. You saw that I have one fracture, and this patient presented with a single restoration that I had just done. And then she came in a couple of days later, and the lithium disilicate abutment was fractured. So that's my only fracture that I have in this model. And stupid me, I was violating every rule because the platform in this 3i implant was way too thin. And I was testing, and also way too short. So instead of the restoration, the titanium coming to here, it really came to here. Well, I was a bit stupid. And you know, you get lulled into the fantasy of materials never breaking. This material can break as well. This is the way it should be ideally, where the titanium comes all the way to the top with a wide enough platform, and in that regard, you should never expect a failure. Remember, my research and our team's research showed that the fractures always occur inside out in a semilunar fracture type of position. So, again, what the core structure is made of would be critical. A titanium abutment is a much better abutment than an all zirconia abutment. Much better, strictly from the point of physical properties. Now, modulus of elasticity, a 1% change can fracture ceramics. You want high modulus, less deformation, and zirconia is a mid-modulus material. Now, can't take anything away from the great Enrique Steiger's work. Zircozon is a very viable product, and certainly within 10 years, most of us, now the first one I saw was done by Carlo Marinello and Nick Pietrobon. That was the first time I ever saw this. But there's no question to me that this is a viable system, and they have the best CAD/CAM technology, and mating properties of any material we've had. And that these are usually made with bars to minimize the flexing of these positions. And these are surface colorants, which can generally be good, but of course could come out. So I'm not saying to you that there's no future in zirconia. I would say to you that whether they're graded materials or others, zirconia is going to change completely to the materials that you think you're using today in confidence with. Prostonomics is an important thing. This is Dennis Tarnow's first office. That's Dennis in the window. And remakes destroy profitability. If you do a restoration once and it breaks, you've made no money. If you've done it twice, you should have paid the patient not to do the dentistry, so you didn't lose it. And you ask yourself, how much commercialization are you actually going to believe in the face of science? Well, bilayer materials are not going away. Bilayer meaning metal ceramic materials are not going away. In complex dentistry, in my opinion, it is a most and the best material we've worked with up to today. So this is a beautiful woman who has a recurrent squamous odontogenic cyst. I did a single crown and I cantilever gingival ceramics. Gingival ceramics came to me from Jörg Strube and Uli Grunder at a fixed meeting in Chicago, and I've done it ever since. So you look at this material and one could recognize it's cemented provisionally. I can tap it out if there's any sign of a recurrence of this cyst. Another patient with a very long 16-year result with gingival ceramics, with the gingival ceramics on the margin. 16-year results. So to me, this is high probability. Wonderful, beautiful girl presented with the fantasy of periodontics, growing too much tissue, and of course this is the result. She's very unhappy with the aesthetics. She shows a lot. We do the Christian Coachman concept of where we'd like our length to be, the midline, what the perhaps golden proportion inflex, where the gingival line should be. We have our hands full. But the biggest problem is the surgeon put the implants way too deep and gave me no area to really drive the prosthetic solution. So I had to ask the surgeon to apically reposition this pontic area, which has happened to be a good amount of my career. Once that was done, I placed these temporary gold abutments and made another provisional restoration. And again, tested that. Tested that. Once that was done, we did our treatment wax to get in the sense of where we were going with the patient, the aesthetic model, whether she liked it or not. In this case, we did a gold subframe. Now, I like in implant dentistry retrievable systems. You can do it in zirconia as well, but gold works beautiful. Or mill titanium, that's going to work just as well to do, but I'm not too good at that procedure. So if you have a gold abutment, bring it out to where you want it to be. Make sure you can floss through it, floss the final restorations in every which way, and one could recognize that this is the quality of Thomas Singh's work and Ron Nevin's perio to apically reposition the surgeon's work that didn't work out very well. Looking at the golden proportion, perhaps I could have raised up the gingival margin a little bit more. Her aesthetic form is nice. Her smile is inspiring. And it's in metal ceramics. And I haven't been stricken dead yet for doing this restoration. And I consider this high probability versus taking risks with material where I have no idea about the chipping and fracturing. The before and after, again, is inspiring. The before and after, again. This is what modern prosthodontics, Jörg, this is what you gave me. This procedure is what you and Uli gave me. And of course, I can't thank you enough. Another patient presented with certainly poor dentistry. This time we didn't do a full gold bar, but we just made individual abutments and screwed in pallidly. So this is all quickly retrievable. And the completed restoration, again, is where modern prosthodontics is today. A major defect Now, Uli once said to me, I know why you do all of this gingival ceramics, because you don't work with good surgeons. Well, maybe, but the bottom line is that's a lot of bone grafting to do. And it may not be high-risk bone grafting, where I have a prosthodontic solution. I can make a gold subframe and a metal ceramic, gingival ceramic restoration to give the patient a general better symmetry and aesthetic result. Another patient presents with complex problems. Perio is done ideally before with the implants. These are the final preparations. Generally, I use Sokransky and Hafford's model. If the patient is not allergic to amoxicillin, I put the patient on amoxicillin, 500 milligrams 3 times a day, and metronidazole, 250. The only problem is they cannot drink any wine or beer or nothing for the 10 days or 7 to 10 days. But if you do that, you will change the whole subgingival complex. There are only 100 papers on this topic. And it's standard protocol at Harvard. So one can recognize if you want to change on a high caries patient, unquestionably, I use amoxicillin metronidazole to change the whole subgingival microbiological complex. And the effects are for 2 years. So to me, that's significant. I believe in the Featherstone protocol, high-dose fluoride, chlorhexidine rinses, xylitol gums and mints. I'm very aggressive with that. A patient presents with metal ceramics, that same one before, and this is the metal ceramic fixed splinted bridge that Thomas Singh did, and this is the lithium disilicate restorations. I challenge any of you to tell me if you can see the difference between one or the other. So don't tell, and Nick Pietrovan used to hit this to me all the time too. The question are you enamored with the new materials because you think it's sexy? Or are you doing something for the patient's long-term behavior? We do very well with metal ceramics, and we do very well with splinted restorations. So I'm pretty comfortable with this. This with implants. The before and after, it's inspiring. And that's what you are all doing today. This is your dentistry just as much as mine. Another patient, complex care, obviously going to lose these teeth. Implant planning is done. Guided surgery, a gold subframe, but first a treatment wax, same way you would do a denture. The subframes are placed, the screws will be milled into this bar, and this is the reconstruction that I've done. Now, I've had the pleasure of doing this type of restoration for over 25 years. And I have a lot of reconstructions like this. I have never done a hybrid. I have never done a zirconia restoration like that. Maybe someday I will, but I'm in private practice. And I'm also a professor that we cannot afford major failures with materials. And our school is not a research lab. Our school is a lab to teach our students effectively and as well to get the best product for our patients. So to me, this is a very reasonable, low cost, low risk restoration. I don't do polymers because they degrade, they leak significantly. Acrylic degradation, there's a whole textbook on the acrylic degradation on micro leakage. One has to only ask yourself, would you want to kiss somebody with this in their mouth? You know, you take this restoration, you put it on the table, and it walks. It's a living organism. It's a living organism. This is what we are doing. And you ask yourself, well, Sig and I have actually took this and ground it up. Most of the bacteria are in the red zone. This is very dangerous stuff. And yet, oh, it's, you know, now as a removable prosthesis, perfect. I have no problem whatsoever. But fixed in the mouth, that's not dentistry that I'm going to choose to do. Now, in a major paper that was done, we realized that the implants in fact work, but that the prostheses do not work. They are very low effective restorations for the dentist and the prosthodontist. The teeth come off, they chip, they break, they wear, and who's going to replace them? And is the patient going to let you take it out of their mouth? And this could happen even a year down the line. Understand the implants are going to work, but not necessarily the prosthesis. So the final case. Patient presents with no anterior guidance. The dentistry was just done in my building. She's unhappy. She certainly doesn't trust dentistry whatsoever. This fixed bridge has failed because of significant decay, and implants are placed. And the fact that they are out doesn't bother me at all, because I'm going to use a gold subframe to change that restoration back to the requirements of the treatment wax, which you see here with the gingival wax position. So I'm going to do what Nick told me to do. I'm going to use a treatment wax to test my model, to make sure the patient likes it, can realize anterior guidance. I'm going to use a digital pantograph. I know that Jorg gets crazy when he sees that. He starts to like shake. I'm sorry, I'm a pathologist. I like articulators and I like them programmed completely. And it only takes me 10 minutes. I do this faster than I do a lateral check bite. So that's important. Once I've done that, Thomas Singh did the laboratory work, checked the protrusive. Now look at the protrusive and look at the protrusive in the mouth. It doesn't have to be perfect, but the more balanced occlusion you have, the less anterior moments to chip and break those teeth. If you have big separation, you have a lot of force on the anterior teeth. Same way you wouldn't want your posterior teeth to be imbalanced, because you may chip and break the posterior ceramics. This is the completed restoration, and the before and after again. This is what we do in prosthodontics. This is what all of you do. This is what is being taught in Freiburg. I know firsthand. So it's not our choices. It's not our ability.